Well, welcome back. And what we really want to go over today is a little bit more about bone structure, okay? And some of these words we've actually talked about before, so hopefully this will be a little bit more of a review for you than what it otherwise would be. So let's talk a little bit about bone structure first of all. And these are words that like I mentioned, that we had probably talked about before. Um, all these words right here. But I want to go over each of them a little bit more individually so you understand each of those a little bit better. So when these are common words that come up all the time. So I think it's important to understand these. First of all, let's talk about the diaphysis, okay? And the diaphysis is basically what we call the shaft, or the main portion of the body of the bone. And that's where this big yellow arrow points to the diaphysis. So this area from here to here would be all the diaphysis, okay? It tends to be, again, in long bones, okay? We see this diaphysis in long bones, okay? And what happens is the long cylindrical area of a bone. It's the main form of long bones, okay? It's like the tubular area. It's mostly that compact or cortical bone on the outside. If you look here, you have a hard shell around the outside. It's pretty thick, okay? So that's that cortical or compact bone on the outer shell. And when inside, here it almost looks like it's an empty tube, but it's not. It's filled with that spongy bone on the inside. And it's called the medullary canal. The medullary canal, or sometimes called the endosteal canal. So medullary canal or endosteal canal, okay? And both those words can be used interchangeably, and that's filled with spongy bone. So there's all this spongy bone that fills this inside, sort of like a PVC pipe, and you fill it with all kinds of like insulating material inside, and that's what this diaphysis is like. So it's the shaft of the bone, again from that area to there. We talked about, by the way, the yellow arrow. It's very cylindrical. It's the main form of long bones. Again, some long and really long bones. This diaphysis is very long, and some shorter long bones. It's much shorter, obviously. And the outer shell has a very thick cortical shell around the outside with that spongy cancellous bone on the inside. Okay, and that's called the diaphysis. Diaphysis. The epiphysis, epi means upon, So the epiphysis is both the distal and the proximal end. So I have an epiphysis out here, and I have an epiphysis out here. Unfortunately, I'm sitting there in the way. So let me see if I can get rid of you. There we go. So I'm done. So therefore, what happens to the epiphysis is this is the area of the epiphysis here, and the epiphysis here. It's mostly a very thin cortical bone shell around the outside, very, very thin, and it's filled mostly with that spongy bone, that cancellous bone that fills the inside, very trabecular cancellous bone inside. At the end of it is going to be the support for the articular cartilage. You see the little blue rim right there, and you see the little blue area right there, and that's the articular cartilage that's at the end. So the epiphysis, epi means upon. Now physis, we had this word before, then physis means growth. And if we look here, there's a little yellow line, and that would be the area where the growth plate would be. So basically, the epiphysis is the area that's upon the growth area of the bone, okay? And that would be that growth plate that would be right in there. So that's the epiphysis. So the epiphysis is at both ends of a long bone, both ends. Okay, and again, one thing I think I really want to mention here, again, we've talked about before, but when we look at a long bone, it doesn't grow along the entire shaft of that bone. It only grows at the ends at what are called the epiphyseal or growth plates, okay? So if I drew a bone here, should have had that last picture show up here. Drew a bone here. It's going to continue to get longer until finally these growth plates close. There'll be a growth plate out here, and there'll be a growth plate out here. And what this growth plate is basically layers of, it's like 5 layers of cartilage that actually change. They transform from being cartilage to actually being bone as they progress across these layers. There's like 5 consecutive layers on there. And they gradually change in the configuration as they go along those layers and converting themselves from being cartilage to actually being bone, okay? And again, these are the zones of the plate. We don't have to talk about that, metaphyseal to epiphyseal. And again, it's called a resting layer, proliferating layer, hypertrophic layer, and calcified layer. And this hypertrophic layer actually is divided into 2 sublayers, which gives it that 5 layers. But what happens, it goes from being a cartilage over here to being bone out on this area right here, okay? So bone grows in length only at these growth plates that are at the end of the bone. Bone grows in width by what's a certain thing osteoprogenitor area, which is called the periosteum. We'll talk about the periosteum. It's a membrane that surrounds the bone. What that membrane does is it lays down one ring, and it lays down another ring, and it lays down another ring, and it lays down another ring, lays down another ring. So as the bone's getting longer at the growth plate, it's also getting wider by this periosteum, this membrane that keeps on laying around, keeps on making like the rings of a tree. Okay, and what happens, it's balanced because on the inside we have that endosteal canal or the medullary canal, and that also widens as well. So that's what happens is in regards to bone growth. Now, that bone growth, like I said, at the end of the long bone is at that epiphyseal plate. So here's an arrow point one. There would also be one that would be down in here. So that'd be also an epiphyseal plate. And it's between the area of the epiphysis, which is, as we know, this area of the bone, and this area right here, which is called the metaphysis, which I'll talk about in a second. Okay, so we have the epiphysis, the growth plate, and then the metaphysis. And again, this is an area of that longitudinal bone growth in long bones, okay, in children and adolescents. Eventually what happens is that growth plate starts out wide, and it starts to get a little bit narrower, it gets a little bit narrower, and it gets a little narrower. Finally it fuses. When it fuses, there's no more growth, okay, and that's when you start to, you stop growing. You know, some kids, 13, 14, they may be growing, 3 or 4 pant size over the course of a summer, and it's because of, that's the area when these metabolically active cells are much more metabolically active. They're growing a lot faster. Okay, when people go through those growth spurts. Okay, again, when that growth plate fuses, there's no further longitudinal growth. It stops growing because again, we can't continue to grow until we die. Otherwise, in fact, what happens is as people, as they get older and they get really old, sometimes they say, I'm getting smaller, I'm shrinking. They're not really shrinking, but what actually happens is the areas between the vertebrae, the disc areas we talked about before, actually get smaller. They get compressed down a little bit more. So people may actually look a little bit shorter as they get older, but they don't get taller because these growth plates will fuse. Okay, and what happens is in a kid, you'll actually see an open area between the bone. You'll see bone here, you'll see bone here, an area that will be clear in between it. And in adults, when this finally fuses, sometimes you'll see just like a white line on an X-ray in mature bone. That's a growth plate. I mentioned then what happens is we have the metaphysis. And the metaphysis is, meta means change or after, okay? And it's the junction, the transition from the diaphysis, which is here, to the epiphysis, which is here, okay? And again, we talked about the diaphysis has a lot of that dense cortical bone on the outside and then a cancellous bone core up the middle in that canal. When we talk about the epiphysis, it's a very thin layer of cortical bone around the outside, and it's mostly that cancellous bone that fills. So what happens is in the metaphysis, two things happen. One thing that happens is the bone starts to flare out, it starts to change in shape. As compared to being tubular, it's starting to flare out. You see a little flare down here, you see a little flare right here. So it's starting to flare. And it's also changing in consistency because now this cortical bone, which is thicker here, starts to become thinner here, and it starts to become more cancellous bone that fills. So in other words, the epiphysis has a lot of cancellous bone with a very thin cortical shell, and that's where we're seeing a transition from what we see a cortical bone down here to epiphyseal bone up in here. And that's what the metaphysis is basically about. The thing that's interesting about the metaphysis is it's a relatively bloody area. So a lot of times fractures in the area of the metaphysis usually heal relatively fast. And a lot of times surgeons, if they have a chance to do a surgical procedure, if they could do it in the diaphysis or the metaphysis, they'll usually do the metaphysis simply because with a greater blood supply, it heals a lot faster. Okay, so that's just a little about the metaphysis. The periosteum. Now we talked about the periosteum very briefly before. And the periosteum is a membrane. Here it actually shows like a little tab that sits right there, but that membrane covers all of the bone with the exception of where the cartilage is. The cartilage is the blue areas at the end. Everywhere else on the bone is covered with this thing called a periosteum. And the periosteum is sort of like a dense, tough covering or membrane, okay? It covers the whole bone except where there's cartilage, okay? And this is what's called osteoprogenitor. Osteo means bone, genitor means generating, okay? And pro means in front of or to do, okay? So as a result, it has the osteoprogenitor capability, so it has the capability to form bone cells. Now I mentioned before that what happens is as the bone is growing in length, it has to grow in width. So we have one layer of bone, then the periosteum lays down another layer on top of that, and that lays down another layer on top of that, and it lays down another layer on top of that, and it lays down another layer on top of that, and the bone will actually increase in width across. by this periosteum. Also, the periosteum is really important in fracture repair. Okay, when fractures, when you get a fracture to a bone or a break in a bone, the periosteum is helping to lay down new bone over that area where the fracture will be. So it's very assistive in regards to helping fracture repair. So the periosteum, which is this membrane, allows a growth in diameter and thickness. We talked about that, as well as helping in fracture repair. Next time you get like a chicken wing or something like that, and you're done with it before you throw it in the garbage, take a knife and sort of like score it. Just run it down the bone. Actually, you'll see you might be able to peel a little membrane off, which is basically that periosteum. It also assists in bone nourishment, because what happens is there's only a couple places where vessels actually come into a bone, and they're called nutrient foramen. Like here's one right here. You can see where the vessel comes in. But what happens is there's small little vessels that will supply the periosteum, that will actually supply some blood supply to the surface of the bone. So it assists in bone nourishment, as well as what happens is tendon and ligament. They have to attach to the bone. What happens when the tendon or ligament comes to the bone, it actually blends with the periosteum, and then since the periosteum is connected to the surface of the bone, and it's attached to the surface of the bone, it allows a greater attachment of the tendon or ligament. I remember when I was doing my residency, we used to always, when we were going down to cut a bone, we'd always go down to the bone, cut the bone, or cut the periosteum, and then take a little thing called a periosteal elevator and strip the periosteum off the bone. What we realized over the number of years is that was probably the wrong thing to do, and we stopped doing that. We basically now just go down and don't cut the periosteum. And we realized if we cut the periosteum off the bone, that it probably retarded the ability to heal. Okay, and made it a little bit slower. The bone still healed, but took slower because now the periosteum had to reattach to the bone and stuff like that. So therefore, we nowadays they just don't fool around with the periosteum a whole lot. They just go ahead and they cut the bone, and they put screws and plates right through the periosteum into the bone. Okay, so that's the periosteum. It's a very important part of bone. We also have what's called the endosteum. Now the endosteum is like the periosteum, but instead of being on the outside, it lines that inside of that canal. Okay, so if we look at that canal, the endosteum lines the inside of that canal. And it also has osteoprogenitor activity. So what happens, it has the same ability to form bone on the inside, just like the periosteum does on the outside. So that's the thing about, so the endosteum is very synonymous with the periosteum, except the periosteum is on the outside because it's peri, around, outside, endo within, so it's inside that canal of the bone. Again, there's still going to be, that canal is still filled with that cancellous spongy bone. Okay. Articular cartilage. Articular cartilage is the cartilage that's at the end of the bone. Okay, it's a hyaline cartilage, and what it does is it's the area of the joint. And what the cartilage does is very smooth. As a result, when the bone is moving, when one bone is moving on another, you don't want a rough surface. You want a nice smooth surface. So two smooth surfaces will actually slide better than two rough surfaces rubbing against each other. Okay, and these rough surfaces will eventually wear each other down totally. So what happens, that articular cartilage, which you see here blue, and we see it down here in blue, reduces shear friction and also absorbs a little bit of shock because it's a little bit resilient. Sometimes you bite a burger and you bite into the thing, it feels like grizzly. Well, sometimes they chip off a piece of the articular cartilage when they take the meat off the bone and package it, and so you say, oh, geez, I don't want to eat this burger anymore. It sort of like turns your stomach a little bit. But basically, you can feel how it's sort of like squishy a little bit. It's very firm, but still a little bit squishy. So as a result, it does absorb a little bit of shock at the end of the bone. The periosteum doesn't cover it, and there's nothing called a perichondrium on the outside. And what happens is, this is where we have a problem with the articular cartilage. Once the articular, think about it. If you take two sticks and rub them together, the sticks become very smooth and you start to wear away the surface of the sticks. If you take joints and you keep on moving joints for a lifetime, eventually that cartilage gets worn away. Okay, you start to wear away a little bit and a little bit more and a little bit more and a little bit more cartilage. And as a result, eventually the cartilage becomes thinner and thinner and thinner and thinner and thinner. What happens is, because there's nothing that actually forms new cartilage, which is called a perichondrium, therefore there's limited regenerative capacity. So in other words, once that cartilage is gone, guess what? Say goodbye, bye-bye, it's not coming back. Okay, you can't replace it a whole lot. I know there's a lot of studies looking at things that might help to assist in replenishment of cartilage, but nothing's really, nothing's really approved at the present time. I know there was a fad for a while taking shark cartilage, I think like chondroitin sulfate, which is basically some of the material that we find in articular cartilage. But you know, there's been no proof to say that really has a whole lot of significant effect down the road, okay? And it really makes more cartilage. Once cartilage is gone, it's gone. So when we talk about things like osteoarthritis is a wear and tear arthritis. Just because you get older, the cartilage gets worn down. And when the cartilage gets worn down, it just doesn't repair itself. It doesn't replace itself. And once it's gone, it's gone. It gets thinner and thinner. It's just like grinding your teeth, you know, and you wear away the enamel on your teeth. Well, as you move your bones and you move your joints, basically you wear away that cartilage eventually over time. So I remember I'd have patients come into me, they'd be 50 years old and say, hey, what's the problem? Say, I don't know. I just want to know if I have arthritis. I say, yes, you do. Okay. And I say, how do you know? You haven't even talked to me. It says, because guess what happens? It's a fact of life. You know, just if you, unless you've been sitting in your recliner, you know, all day long until you get up to go to bed, you know, guess what? You're going to wear away your joint just by activity. Okay. And that's one of the bad parts about cartilage. It doesn't regenerate itself. That medullary cavity, we've talked about that before. Here it shows again, it looks like it's a tube, but it's not. It's filled with that cancellous bone, okay? Filled with that soft, spongy, again, I don't say soft, man, that's a bad word. Say spongy bone, that cancellous bone, okay, that's inside. And it's in the center of the diaphyseal region, okay, is that medullary cavity. So if we look at that cavity would be this whole area all the way down through here. That's that whole medullary cavity that comes down here along the inside diaphysis. Again, that medullary cavity is usually filled with fatty marrow in adults, okay? And the fatty yellow bone marrow. At the end of some long bones, we're able to still produce blood cells, but by the time we get to be adults, we've actually lost that in most of that marrow area in the middle of the diaphysis. So basically that medullary cavity is filled with a yellow bone marrow, which is, again, yellow because it's fatty. This is something we talked about before. I'm just going to finish off with this very quickly, very briefly. We talked about types of bone before. We talked about compact bone. I've talked about even in this particular video, as well as spongy bone. And compact bone, like I said, is that cortical bone and stuff like that. Now, this over here is sort of like an image of a femur or a picture of a femur. And what they've done, they split it longitudinally. And what we actually see when we look at this, outside, you see how very thick this dense area right here is that cortical bone, that cortical compact, also sometimes called dense, like I mentioned in a previous video, also sometimes called dense bone. Compact bone, cortical bone, dense bone, they're all there. And what happens is this is the diaphysis, here's the metaphysis, and the epiphysis will be out here. And you see how that cortical bone becomes thinner the further distal I get. Okay, or proximal in this case, proximal distal going in the other area. But what happens is you see how that cortical bone is this thickness here, this thickness here. Now it's a very thin cortical shell around the outside of the bone. And again, it gets thicker as it goes more distally here. So that's that compact bone. And that spongy bone is everything else that's inside there. So when we start to look at this area in here, as well as down the medullary canal, that's all that spongy bone. That spongy bone, like I mentioned before, is also called cancellous bone, trabecular bone, and sometimes also called medullary bone. Okay, medullary bone. If you see the word that's that, because it fills that medullary canal, which is that, or that endosteal, and sometimes it's called endosteal bone as well, because it fills that endosteal canal that's in there, and that's that spongy bone. If I looked at the structure of compact bone, again out in here, what happens is bone actually has cores. Okay, if we look at this, we look at this microscopically, there's cores, and these cores are called osteons. Okay, and basically these osteons are lined up, and this is probably, you don't have to remember, but I think it's sort of interesting to know. They're parallel to the long axis of the shaft. So I'll have an osteon, an osteon, 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 osteon. They're lined up parallel. And what that does is that resists bending or fracturing. There is a little bit of a bend to bone because part of bone is actually collagen, and the collagen has to be there for the calcium and other materials to be deposited on the collagen that makes like a web. Okay, that we have what's called a matrix with this web of those collagen, and then what happens is then all those crystals can be deposited on that particular web. Okay, and what happens is, again, the osteons will also lines of stress will change or modify it, and something we don't have to know. There's something, if you ever hear it down the what's called Wolff's law. Wolff's law says bone changes according to the stress that you place on it. So if I place more stress on an area of bone, it will actually change in shape and configuration. Okay. Again, one other thing I should mention about compact bone is compact bone tends to be thickest in areas where the bone needs more support. Now, again, if you look here, I have a very thick cortical compact bone in there. And the easy way to think about that is, I think I mentioned this in the last video, if you take a pencil and you hold it at two ends and you bend it, where's it going to break? It's going to break in the middle. It doesn't break at the ends by your fingers. It's going to break in the middle. The bone is actually trying to be pulled apart. And if I take a shaft like this, I start to bend it, it's actually trying to pull the bone apart at both ends, okay? And that's where we're going to break in the middle. So therefore, this area would be more subject to fracture simply because it's the area where the greatest bending stresses would be on the bone. So therefore, it has to be thickest. That's why that cortical bone is thick in this area. Okay. The other type of bone I mentioned again is spongy bone, and spongy bone is also called cancellous bone, trabecular bone, medullary bone, sometimes endosteal bone. And basically, instead of having these cores of bone that are very tightly packed, very close to each other, basically we have these little spicules all over the place. Okay, and these little spicules form what are called trabeculae. That's an important word. And the trabeculae, that's where you get the word trabecular bone. Trabeculae are struts. And these struts are basically all over. And then what happens is what fills the inside between all these struts is all the marrow, either yellow marrow or red marrow, wherever it might be. Okay, so those open areas are for red marrow, or at the ends of some long bones in adults, and yellow marrow in the other areas. Okay, but there's no osteon, there's no core-like structure that we find, just all these struts of bone that are made. Okay, and that's what we see with spongy bone. I think that's probably all you really need to know. There are things like osteocytes. We talked about osteocytes, osteoblasts, and osteoclasts in a previous video. And again, what happens if we look at the location of spongy bone, most of it's in the area of the epiphysis and the metaphysis, okay, as well as down that medullary canal. So the central medullary canal, along the metaphysis and epiphysis and long bones, okay? If I look at short, flat, and irregular bones, what happens in those situations, what you'll actually have is you'll have a layer of compact bone like that, a layer of compact bone like that, and then what happens is in the middle that's filled with this cancellous bone. It's like a bone sandwich, okay, and that's what you see with a flat bone, okay. These trabeculae also, those struts are lined up according to lines of stress, you know. And here, you know, if I erase this and you look that up in here, you see how you get sort of an impression there's like a web or a framework inside there of all this cancellous bone, you know, in this area in here, so like all this framework in there. But what happens is these struts are not just laid down haphazardly, but they're laid down according to lines of stress. And because of that, okay, it's the engineering thing. They provide something like internal struts that provide increased stability. So even though this bone doesn't look as hard as it does down here in that dense cortical bone that we find in the diaphysis, the bone is still pretty strong in this area. One of the problems is that when people have osteoporosis and they start to lose the calcium and the crystal nature from their bone, the areas that first is evolved is the spongy bone. They start to lose these struts, and when these struts start to break down, as people become more osteoporotic, okay, the bone be more likely to fracture. Okay, so basically the spongy bone normally in normal people aligns well, supports and protects the bone marrow inside there, and because of the alignment of all these little struts, it makes the bone quite strong at the very ends of the bone. So it doesn't, unless there's something pathologically wrong with the bone, it's actually pretty good. Okay, so what we've talked about today is pretty much a review of what we had before. We did talk about the different areas of the bone, you know, epiphysis, metaphysis, diaphysis, metaphysis, epiphysis, and then the growth plate between the metaphysis and the epiphysis. Talked about the periosteum and the endosteum, both osteoprogenitor, able to produce new bone, the endosteal or medullary canal, articular cartilage, blah, blah, blah. We talked about all those things. Those are important words because those words come up very frequently in a lot of different areas. So I think I would probably want to know those words. Then we talked a little bit more, we've talked about it before, but we talked a little bit more in regards to the different types of bone, you know, spongy bone, you know, which is the cancellous, trabecular, medullary bone versus cortical, dense, compact type bone. So hopefully this will all make more sense to you and these words will all become second nature to most people here. Okay, so in the meantime, wait for your next video, which will talk about some bone conditions, which is actually pretty cool. And we'll see you later.